Hello, hello, testing the mic. Thank you. Good afternoon, and a warm welcome to this session that is going to look at HIV drug resistance and resistance considerations in different areas. We're trying to reach two of our presenters who will not be here in person. They will present virtually. So our IT team is doing everything possible to make sure that we have uninterrupted presentations. So I would like that we continue to settle in. In the next 5 minutes, we will start. Good afternoon again, and a warm welcome to this session, which is potentially going to be exciting. It's to do with microbial resistance across different areas. And we are privileged today to have three experts who have been working in this area for some time. And I'm going to introduce them when it is time for them to make their presentations. Two of them are unable to join us in person, and so they would make their presentations virtually. But we have one who will be presenting first, and she is going to give us a talk on AMR, antimicrobial resistance, and risk of infections with antibiotic-resistant bacteria in people living with HIV. She's in the person of Professor Catherine Krasner. Catherine is a fellow of the Royal College of Physicians, and she's a clinical microbiologist and an internationally recognized expert in tuberculosis and HIV. She's a member of several WHO guideline committees and that is focused on diagnostics, antimicrobial resistance, and is a professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine. My school, I think. She's based in Zimbabwe, and where she leads several studies in multi-country consortia on tuberculosis, sepsis, and antimicrobial resistance. Catherine also co-directs the Health Research Unit in Zimbabwe at the Biomedical Research Training Institute. Apart from being highly cited and published researcher, Catherine leads 2 research capacity building networks in South Africa and is currently supervising a number of PhD students. It's a privilege to have you and to give us a talk on antimicrobial resistance and risk of infections with antibiotic-resistant bacteria in people living with HIV. Catherine?
Thank you very much, and thank you very much for inviting me. So I'm not really an HIV expert. I'm not a virologist. So I really work mainly with bacteria. And I don't know if it's possible to bring the presentation up. Yeah, so I will be speaking about antimicrobial resistance and how that relates to HIV, and if it's more likely in people with HIV, and what kind of data we have at the moment. But really one of the big take-home messages will be that the data is very scarce. I think something is happening, that's great.
As we earlier on indicated, we have 2 other presenters, and they would be online. So we try to coordinate with their areas.
I might just continue speaking, because then we can skip a couple of slides.
Yes.
In the interest of time. So, okay, next slide, please. Or can I maneuver that myself? Am I in control? Oops. No? Perfect, thank you. Perfect, thank you very much. Could you move it to the next slide? Perfect. Okay, thank you. So just a very brief overview for people who are not that much in the antimicrobial resistance kind of sphere of things. In 2019, we had an estimated almost 5 million deaths associated with bacterial infections, and it was the 3rd leading cause of deaths in 2019. And it's really predicted to come even higher up on the agenda and becoming the leading cause of death in the future. Now, next slide, please. When you're thinking about people living with HIV and you're thinking about the causes of hospitalizations, you can see, and I appreciate that you might not be able to see that in the back, but there are still some seats in the front, a systematic review which was published in the Lancet HIV in 2015. by Ford et al., where they looked at what were the reasons or the causes for hospitalization. And there were 99 studies included with a total of almost 400,000 people. And really the bacterial infections made up 25% to a third of hospital admissions. So clearly it's a very important area, and having a bacterial infection is the first step to then having a bacterial infection with antimicrobial resistance. Next slide, please. So when you're looking at the causes of death among people living with HIV admitted to hospital, then a fourth of the deaths in adults is actually due to bacterial infection, and more than a third of death in children is due to bacterial infections. So again, it's not just that it's the cause of actually being admitted, but it's also one of the main reasons of hospital death. Next slide, please. So we did a systematic review, and that's really the work of one of my PhD students, Joanna Olaro, who looked at what is the evidence of antimicrobial resistance in people living with HIV. And just to say, this review, we actually excluded studies on STIs, so gonorrhea is not part of it, and TB, because tuberculosis is a bit of a separate kettle of fish. So these were all the other bacterial infections except STIs and tuberculosis. And what you can see, the bigger the blob, the more studies from that area, and you can see two very big blobs, and those big blobs are essentially from the US and South Africa. There is a lot of gray, so a lot of countries do not have any data on antimicrobial resistance in people living with HIV, and that relates especially to places in kind of East Africa, in West Africa, but also North Africa, and then in Central Asia and Southeast Asia. Next slide, please. So when you think about antimicrobial resistance and which organisms are kind of the top priority, so the first thing is obviously thinking about gram-positives and gram-negatives. So in the gram-positive spectrum, Streptococcus pneumoniae, and a lot of you, you know, like 20 years ago, that would have been one of the main infections people living with HIV would have presented with. And Strep pneumo, in contrast to a lot of other bacteria, just resistant or susceptible. It's due to the penicillin binding protein, and it's kind of a stage-wise process. You basically get increases in the MIC. It doesn't get directly from susceptible to resistant, and you can overcome that to a certain degree, either with higher doses or with ceftriaxone. But among these 22 studies, and not all of these studies were actually invasive strep pneumo infections, the top part, the top 4 studies are essentially either pneumonias or carriages. There was a 2.2 times increased odds ratio for people living with HIV having non-susceptible strep pneumo compared to people who didn't have HIV. And that's the same in the invasive studies versus the non-invasive studies. And there's obviously a lot of heterogeneity around that. Next slide, please. So the second most prominent, or like as an infectious disease doctor, what you always fear is a Staph aureus. So Staph aureus is, in this case, then methicillin-resistant Staph aureus, MRSA, also a very important organism. And you can see 44 studies which contributed to this pooled odds ratio of 2.02. And on the top, carriage, on the bottom, infection, not necessarily invasive infection, because obviously a lot of Staph aureus are skin infections. So again, consistently increased risk in people living with HIV. Next slide, please. And now, you know, largely when people speak about drug resistance, what we are really, really concerned about is actually gram-negatives. And gram-negatives, which, you know, a lot of you might be clinicians thinking about ESBL gram-negatives or carbapenemase producing organisms, which then it becomes really difficult to treat somebody with sepsis. And sepsis due to Staph aureus, also not great, but really most of the sepsis you will see in hospitals is essentially due to gram-negatives, and altogether only 8 studies looking at the prevalence of cephalosporin resistance among gram-negatives. 4 of them carriage studies and 4 of them invasive studies. And again, the pooled odds ratio very near to 2. So consistently across these different organisms, a higher risk among people living with HIV. Next slide, please. So that kind of brought us to the realization there is like a blank map, especially in kind of Central Africa, Central Southern Africa, apart from South Africa. And it's especially gram-negatives where we know very little about. So we did a study here in Harare about antimicrobial resistant in gram-negatives. We recruited adults presenting to primary healthcare clinics, so not from hospitals, so really the step before 10 primary healthcare clinics presenting with at least 2 symptoms of urinary tract infection. We collected the urine sample, and 36% of the people presenting were living with HIV. So it was over 1,000 people we recruited. We had a culture positivity rate of about a third, so 29%. Microbiologists, I don't know how many are in this audience, but they will, if you are working in a high-income country, that's very unusual. And some of the reasons for that, but that has been consistently shown across kind of African studies, might be that people actually have STIs, and we have looked into that, and a lot of people do have STIs, and it's not really a UTI they are presenting with. But then also a lot of people do get antibiotics before they come to the health facility because there is an excess fee, and it's very difficult to pay for that. The vast majority, as usual in UTIs, E. coli, so 75% E. coli. Next slide, please. So if you're looking at the antimicrobial resistance across these across these antibiotics, you can see, no surprise, Cotrim, very high levels of resistance, over 80%. And in red here, people living with HIV, and in gray, people without HIV. And you can see that consistently across all antibiotics, people living with HIV had a higher prevalence. Cotrim, there isn't that much more to go with regards to increasing resistance, but amoxicillin, which is the first-line treatment for UTIs in the public sector, 80% resistance. Even Coamox, which you would kind of hope an E. coli, you could treat that with. And then ceftriaxone resistance, 25% ceftriaxone, or 26% in people living with HIV, and 13% in those without HIV. Again, an adjusted odds ratio, as we have seen before, of 2.13. And I'm saying adjusted odds ratio because obviously there are a lot of factors which influence why people living with HIV have more resistance. But just to point out, chloramphenicol, I know lots of people are not that keen on it, but it's still quite a good drug. It's oral. There isn't that much resistance because we haven't been using it very much. Nitrofurantoin, damn cheap, produced in Zimbabwe, also something which should be on the menu, similar to fosfomycin, which is also not here, but we did the resistance testing and there was very low resistance. Next slide, please. So if you think about the interplay of risk factors and AMR among people living with HIV, we did this DAG to really make us think about why do people have increased risks. It's not due to their HIV, it's much more due to the fact that they have much more increased kind of healthcare utilization, so clinic attendances, hospital admissions. Therefore, whenever they get admitted, there will be an antimicrobial prescribed. There's high prevalence of comorbidities. And then there is also, the leaky gut, which also means that people are much more exposed to kind of infections. So there's a lot of reasons why HIV or having HIV is a risk factor of actually having antimicrobial resistance. And I think that's important to note when you think about somebody being admitted with acute sepsis and you have 25% ESBL in the community, then you can assume that your ESBL prevalence in the hospital is relatively high. Next slide, please. So just to say, and that's going to be my last couple of slides. So what can we do about AMR in people living with HIV? I mean, obviously, we need to treat with something which works. But at the moment, we have very little data to actually understand the burden. As you have seen, 8 studies, very few, and these studies on gram-negatives, very few from Africa. And we really need to integrate. I mean, there is this whole push for surveillance, but I always say, why survey if you're not doing diagnostic testing? It is much, like surveillance is the second step. Just sort out your diagnostic testing first so that you can actually make sure that you treat your patient. But if you do surveillance, don't just do laboratory-based surveillance. Make sure you can link it to clinical data, because only if you can link it to clinical data will you be able to stratify the analysis by HIV. You need to test for it, and you need to test for it, and you need to test for it. Phenotypic microbiology is not easy, but it's something you're in for a long haul. You need superb quality management in order to get really good results. And we have very little phenotypic phenotypic microbiology done well in a lot of settings. In the absence of actually clinical, like routine data, you need to have research studies reporting AMR by HIV status. It's not a big ask. Usually people have these data, and then evaluate impact for mortality, morbidity, cost, and quality of life. And just my last slide, if I just want to point out, if you can move to the next one, we can jump over that, what the new kind of diagnostics are. But just to say, the WHO Global AMR research strategy has acknowledged that actually people living with HIV are a specific subgroup where all of the different things that research agenda has in it should be stratified by HIV to actually get some more data for it. And you can read the whole strategy yourself. And that's it. Thank you very much. If we can jump to the next slide.
Thank you very much. Let's give a hand. This is a good presentation, giving us some perspectives on resistance, antimicrobial resistance. And I'm happy you spoke about the fact that it is not because the individual is living with HIV, but the kind of exposure in terms of clinical attendance and the use of antibiotics at community level and all that are all the things that influences it. We will move to the next presenter, and I hope he's online, ready. That is Jordan. Is Jordan online? If Jordan is not online, then we'll move to Merfin. We have the record voice from Michael Jordan. Okay, we would, while you make that ready, it's Merfin, Dr. Merfin Pundu online. If he's online, we'll take his presentation before we move to the recorded one. Both were not able to make it in person. I think we'll move. Do you have the recording of Jordan? If we have the recording for Jordan, we can take that one at this time. As we get the IT team to play the recording, let me read a brief profile of Jordan. Prof. Michael Jordan. Yes, okay. So there is a backup, actually. You know how it happens when you have virtual things and not working. So we have someone who will make the presentation on behalf of Jordan, and we can pull the presentation up for him. Just give us some time to sort this out.
Good afternoon. It is an honor to be speaking at this.
Yes. So you can pull Jordan's presentation on, and then we'll get his backup.
Maybe I'll quickly introduce myself
Yes.
while we're waiting for the slides to come.
Introduce yourself.
Yes. Hi, everyone, and sorry, I'm crashing the party. Things are getting heated in here, I can see as well. So my name's Ajay Rangraj. I work at WHO HQ with Michael Jordan. I'm the lead for advanced HIV disease. So I work on AHD, a little bit of treatment, as well as the cervical cancer elimination initiative. So I'm just filling Michael Jordan's shoes, and I'll try to do semi-justice. Hope it works.
Good afternoon. It is an honor to be speaking at this session today.
Okay, so Jordan is not here, and he's going to make the presentation on his behalf. And as you can see being projected, it's HIV drug resistance consideration in the era of DTG, that is dolutegravir-based antiretroviral therapy. This is an area that has been ongoing for some time now, and we are very pleased to hear on this. Please proceed.
Thanks so much. So next slide, please. So Abhi, I think what the presentation really covers is just an overview of what we currently know in relation to DTG resistance specifically across different types of studies. So the first one is that I'll talk about is in clinical trials, and I'll go on to cohorts and then some other data available. So the prevalence of DTG among people living with HIV with failure to suppress viral load in clinical trials. So typically there's been about 6 scenarios that have been described. The 3 most important ones are really ART naive people with HIV who started DTG with 2 NRTIs, and currently there's about 15 trials, and which accounts for about 4,588 people living with HIV. I'll just skip to scenario 3, which is ART experienced people with HIV with failure to suppress viral load on an NRTI regimen who was switched to DTG with 2 NRTIs. So that's 6 trials and accounts for about 1,400 people. And then scenario 4 is ART experienced people with HIV with a suppressed viral load who were switched to DTG. And we have some evidence from about 4 trials, that's about 930 people living with HIV. So across these studies, they found that the prevalence of acquired integrase strand inhibitor associated drug resistance mutations was about 1.6 at between week 48 to 96. And in scenario 3, it was 2.9 by week 24. And I think in contrast, the prevalence of drug resistance in these the other remaining scenarios were actually much lower. But I think quite importantly, so I think so far the data is reassuring. Oh, sorry, next slide, please.
Away from clinical trials.
So I think, the levels of DTG resistance are about where you would expect from the clinical trial evidence. However, when you start looking at cohorts, the numbers tend to be a bit higher. And also it really depends on what patient population you're selecting, because again, it's of course depending on how representative the sites are. Is it just a isolated site that you're picking the cohort from? So you can see there are 4 countries listed here: Uganda, Ukraine, Mozambique, and Malawi. And you can see the populations are quite similar for Uganda, Ukraine, and Malawi, where it was an individual had to be on ART for at least 9 months on a DTG-based regimen, and then have a DBS or a plasma test with a viral load greater than 1,000, and typically greater than 18 years of age. Notably in Uganda, this was above 15. And you can see that the rates of DTG resistance are higher than we saw in clinical trials, but about where you would expect. However, in Mozambique, a clinic-based study decided to choose treatment experience. These are heavily treatment experienced individuals with an who were transitioned to TLD and had an unsuppressed viral load. And you can see that the resistance rates here are almost 19.6. And I think this is not necessarily a cause for alarm, but I think is an important indicator that we need to have a better understanding of what these treatment experienced patients consist of, like as in what are the resistance profiles of these individuals, and in that it might be more complex than we perhaps anticipated in relation to DTG. Did the slide change? Oh, sorry, could you go back, please? So I think, importantly, I think the transition with an unsuppressed viral load was associated with a higher risk of failure after TLD initiation. So this had an adjusted ratio of about 2.14, but was not a significant risk for the emergence of DTG resistance, which I think is an important takeaway from what we know. Next, please.
These data from South Africa.
So this is just sort of a summary of a South African study regarding ART exposure when taking DTG with a high viral load. So maybe it's a little bit small, but I can read out some of the key things here in that typically we've seen there is a general increasing, there is an uptick in terms of resistance when it comes to any form of resistance, particularly when there was successful HIV-DR testing. You can see that any form of resistance, this is sort of the lower horizontal band you can see there. You can see that in 2019, it was around 72%, that is any form of resistance detected. And then it has sort of declined in 2022 to about 57%. essentially DTG resistance in
I chose
patients
data
with,
from Uganda's
previous
national
slide, please.
survey.
Yeah. DTG resistance in patients with laboratory confirmed DTG exposure increased from 2.7% in 2021 to 11.9% in 2022. And I think this is something that we need to take serious cognizance of, in the sense that we should have a good sense of at what rate is DTG resistance emerging in our population. Next slide, please.
I chose data from Uganda's national survey of HIV.
This is a study from a national survey of drug resistance in Uganda, and this is really in the younger age groups. And this is really from a random sample of remnant viral load specimens from children under the age of 15 and adults above 15 with a viral load, unsuppressed viral load on DTG-based ART for 9 months. So you can see that the major DTG drug-resistant mutations in the 0 to 14 years was about 7.1%, and above 15 years is about 4.4%. And intermediate to high-level DTG resistance was about 6.6% in 0 to 14 and 3.9% in the above 15s. Next slide, please. I'm almost done. I'll speed up, rather. So I think the next important population, so I've just tried to sort of walk through the different populations, and I think the next significant population we have is in pregnant and breastfeeding women in South Africa. And I think this has very serious implications for prevention of vertical transmission. And typically the identified mutations in the 3 cases were largely similar in that there were E138K, G118R, and T66I, and I think there was an A in the other 2 cases. Next slide, please.
Indeed, Haiti has recently published a case
So this is, I think, so this is the last subpopulation that I'll be talking about, which is in a perinatally HIV-infected infant associated with maternal TDF and DTG use in Haiti. So the infant had a number of mutations detected, particularly the R263K, M184V, K103N, and the mother was receiving TLD and was unsuppressed, and drug resistance testing of the mother was not performed in this case. While it's, we are unable to ascertain if the infant was infected with a DTG resistant virus or if resistance was selected because of injection of subtherapeutic levels of DTG. Previous slide. It's like, oh, sorry, never mind. Correct slide, sorry. Was selected because of subtherapeutic levels of DTG in the breast milk. The infant did not receive an NRTI containing combination, postnatal prophylaxis particularly. So I think we can conclude that the observed resistance is attributable to infection with a resistant virus itself. Next, please.
Out to DTG resist in the ideal cohort.
So this really, I just wanted to quickly talk about HIV-1 drug resistance in people on DTG-based ART. And I think the real takeaway from this is that, DTG monotherapy is a risk factor for DTG resistance, dual therapy, and then potential or low-level NRTI resistance and intermediate or high-level NRTI resistance. So resistance to NRTI may not affect treatment failure risk, but could increase the risk of acquiring resistance in the case of failure. And I think that's an important sort of juxtapose when we're talking about these things, because it's very easy to associate one with another. It's fine. You can go to the next slide.
In 2022,
that was on time somehow.
HIV drug resistance, of course, is a particular concern.
So so I think the next area which I think a lot of people are concerned about is in relation to CAB-LA. And I think this is, of course, we are very excited about the introduction of CAB-LA into HIV prevention guidelines. And there's currently one trial, the HPTN 083, that's looking at this and observed in-state resistance in 10 of 18 cases with recent CAB-LA exposure. It's worth noting that the definition is an injection within 6 months of the first positive HIV test. So in all cases, cross-resistance to DTG was predicted based on the pattern of INSTI resistance-associated mutations. So of course, I think studies are really ongoing to assess the clinical response to INSTI-containing ART among people who have previously received CAB-LA.
The global transition to
oh, that works perfectly, actually. Yep, I have 2 more slides.
monitoring
So I'll try to speed up.
HIV drug resistance,
The other next thing is
declared
HIV drug resistance surveillance and a focus in the DTG era. I think this is obviously a need in terms of to understand DR in children, adolescents receiving HIV, as well as pre-treatment HIV DR.
As of July
And of course, WHO in 2021 launched the strategy for the drug resistance. I'll maybe skip through these slides in the interest of time. Yeah, could you go to slide 13, please? Thank you. So I think, just to conclude, the low prevalence of viral failure with this sort of selected insti drug resistance in people on first-line DTG containing regimens really helps sort of give us confidence in that the decision to switch from NNRTIs to DTG was a good one as part of first line. And overall, there is low prevalence of DTG resistance, and there's also evidence to suggest that non-adherence could be the primary cause. And I think this is a twofold issue, and I think really the emphasis here is that programs should prioritize making sure that individuals are adequately counseled, and this is really not we can't really assign blame necessarily in one direction. I think it's programs' prerogative to make sure that every individual understands, and particularly in an era where we're talking about say zero and U equals U, so on and so forth. And also, in summary, really, the risk factors for acquired DTG resistance include this issue of background NRTI resistance, DTG mono or dual therapy, pediatric population, and suboptimal adherence. And I think PrEP is highly effective, and resistance concerns should not affect scale up. But I'll stop here. I do have one more slide, but I'll stop here.
Thank you very much, and let's give him a hand. You've really represented Michael very well.
I hope so.
I know Prof. Jordan would have gone.
I did have one point just to conclude,
Yes,
which I
please
couldn't
make it
quite
quickly.
get. Yeah.
Yes.
So I think I did want to make the point about genotypic and phenotypic resistance. And I think a lot of the data looks very concerning, but I think we really need to understand what this genotypic change actually implies in the real clinical world. So I think this is true of antimicrobials in general, I think. So, and I think it's no different in HIV DR as well. Thanks.
Thank you very much again. I think that this area is very, very exciting. And for those who probably are not inclined to all the mutation figures that and labelings that you see, the key thing is that cabotegravir long-acting is becoming something that we'll be using for prevention. And we'll continue to see how we monitor those that will be failing on DCG-based regimen. So this is good, and we'll be looking forward to more things on that. Are we online with Mifan? If he's online?
Yes, I am. Can you hear me?
Yes, I can hear you loud and clear.
Great.
So we'll be listening to Dr. Mefin Mpondo, who will be giving us a lecture on the policy implications addressing the threat of antimicrobial resistance for patients living with HIV, for people living with HIV. Mefin is a public health specialist, a director of the REACT Africa and the Partnership Engagement Lead for the International Center for Antimicrobial Resistance Solutions. He has over 25 years of experience in international global health and security. His CV is quite long, so I'm going to cut it.
Just skip it.
But one thing, he's a strong advocate for action on antimicrobial resistance and equitable access to healthcare for all. Mefin, please proceed with your presentation.
Yeah, thanks. I think I'll be, thank you so much for the invitation, and thanks for the speakers that have gone before me. Are you sharing
Hold on,
my
Mefin.
slide?
I want to make sure that the IT team had the presentation on for the audience. And he's on. We can see you now via video, and we can get your presentation. If you can put it on the presentation mode, and then you can drive it from there.
Okay.
Yes, we can see it. Please proceed.
All right. Next slide. Yeah. So I think the angle that I'm going to take is go over some areas in policy and where there's some convergence when one is looking at resistant patterns that we see in people living with HIV. This slide and the information here, I think, was already dealt with by the first speaker, essentially really making a point that that there is an increase trend in people dying from drug-resistant infections, and the Graham report actually was able to build that evidence, really connecting antibiotic resistance with actually deaths in the region. Just in 1 year, we lost about 255,000 in the African region, and 1 in 5 children who died that year died from even a vaccine-preventable disease. Next slide. So this is a global problem that we keep seeing. If you look at this slide, the first graph to your right, my left, is that, that green area, it shows you that the burden is highest actually in sub-Saharan Africa. And even when you look at this slide, diagram on the right, you see that the global burden actually in 2019 again actually tilted towards the African countries and Southern Africa especially. Next slide. When we look at the at the African context, of course, we see that we have the largest burden really of infectious diseases. We have issues around the social determinants of infectious diseases, which I believe actually are the major driver of really antimicrobial resistance. And then we look at, of course, most of our population do not have any universal health coverage, and so they pay out of pocket. We look at the issues around the critical shortages of antimicrobials in the lab systems. You're looking at not having the culture borders, not having consumables. Those are clear challenges that we have. Of course, we have seen a decline in funding in the budgets that go into the the ministries of health. Roughly Nigeria now, it's about actually 7% or so, but I mean that trend has been seen almost across the region. Next slide. Yeah, again, I think this is well known in terms of the effect of MR on the continent, but also, in the developing countries. Again, we see that across Africa, we lose up to 5% of the GDP as a result of the MR. And again, we see that the children and other vulnerable groups are more impacted by this, and also the fact that we are seeing